Well, good morning and good afternoon and good evening, probably everybody. My name is Vanya Gant, and I wish to welcome you to this really interesting and timely session for ISAC to discuss several aspects of this increasingly burdensome condition referred to as long COVID. I've got several announcements to make. My first announcement is that I'm afraid that our speaker, Menno, who's going to talk from UMC, talk to us about the immunological consequences of long COVID, has been taken ill. So I'm very sad to report that unfortunately Menno will not be with us today to discuss that. So this meeting will probably run a bit less long. That's the good news. The other good news, of course, is that it does mean that we might be able to be slightly more relaxed as considers possibly slightly longer question and answer session. And so probably that's all the announcements I have to make now. I was quite amazed to see that some 459 of you have registered for this session. I'm not sure we'll get 459 people logged in, but we're certainly optimistic that we'll be way north of 300 people. And it might be a bit difficult for me to talk into the digital void. I do prefer talking to people I can see. So it's not that easy for me to talk into the void knowing there are 300 or 400 people there, and I shall do my best. So the other announcement I'd like to make is I think because we have a condensed schedule of 3 speakers today, what we should do is have the 3 presentations. And so please do send in all your Q&As. As time goes on. We won't be ignoring you simply because we're running through the program. And what we will do is we'll have a big catch up at the end of it, and where you can address your questions to any of us 3 speakers as you see fit. So without further ado, I think I shall crack on, and I shall be giving you my presentation, which I very much hope you can now see on your screen. So I'm going to talk about immunological changes in long COVID. These are very preliminary data, but as you can see, I will talk to you about why they're preliminary and how they came about. And I present this as a consultant physician in microbiology and infectious diseases. The picture there is University College London Hospitals in London, strangely enough, and this is the National Health Service Hospital. Although the work I shall be presenting really relates to some work that we got up and running very quickly at the physician's clinic, which is not part of the NHS, and perhaps I'll talk a bit more about that in a minute. My interests, by the way, are in immunology. I have a PhD in cellular immunology, and I've been a frustrated non-practicing cellular immunologist for many years. Maybe even if it's late in my career, I'm redeveloping an interest in this because of COVID. So let's just kick off then. So first of all, some definitions. I think the long COVID thing is a patient movement, and it's certainly, I can't speak for around the world, but in the United Kingdom, it was the patients themselves who started flagging to the doctors to say, look, I had COVID, it was proven, and I'm feeling terrible and I'm not getting better. And we soon realized that there seemed to be a syndrome. And the official governing bodies in England, the National Institute for Clinical Excellence, the Scottish Institute, and the Royal College of General Practitioners that deals with the primary healthcare system in the UK, agree these definitions. And they thought they'd split it 3 ways. They thought they'd split it into the acute disease, which we clearly know and have a lot of unfortunate experience with. Then they split it into ongoing symptomatic COVID-19, which is where people just didn't get better quickly, and they still had residual symptoms from 4 to 12 weeks. And then the true full-blown COVID-19 syndrome. And this is a syndrome that is considered and defined as lasting for more than 12 weeks and have no alternative diagnosis. These are, of course, only guidelines. They provide a framework, I suppose, for assessment. And but as you will see, COVID-19 is protean in its manifestations, and it is not as easy as that at all. I have to apologize. This slide is 24 hours old. As of yesterday, over 230 million cases, getting on for 5 million deaths. But I thought I'd throw that in together with a Swedish study in really healthy young adults that came out not that long ago. And what they showed is that 1 in 10 people who had COVID, and it didn't matter whether it was severe COVID or not, sustained moderate to severe symptoms up to 8 months after being infected. And if you translate that to 230 odd million, what this is telling you is that probably there's 40 to 50 million people in the world today exhibiting symptoms for 5 weeks or longer. And probably half of those go on to still have symptoms for 3 months or longer. And that is a huge number. The United Kingdom Office for National Statistics also had a look at this. And these are old data. This is June. They came out in the public domain with a statement suggesting that there were over 950,000 people in the United Kingdom alone who had some or most or all of the COVID symptom family, if you want. So this is a very considerable number of people. It gets more complicated than that. I think as everything developed, we were originally talking really a lot, were we not, about long COVID or acute COVID being particularly destructive and dangerous for people in their 60s and 70s and 80s, or those with diabetic or obesity comorbidities, to name it too. But it would appear that long COVID does not follow that demographic at all. If anything, long COVID seems to favor younger people with no pre-existing comorbidities. And as you can see in this slide, age groups all the way from 18, let's take to 18 to 65, as you can see there, a very considerable number of those people, however young they are reporting symptoms of long COVID and fit the long COVID diagnostic definition. It is not at all associated, well, almost not at all associated with previous comorbidities. And some of these young people are really, it is a life-changing event for them. You have people who would think nothing of cycling 80 kilometers on a Sunday morning just for fun, who find it difficult to go from the bedroom to the kitchen for months on end. This is a very real and very challenging and destructive condition. These also some data from England showing the prevalence of symptoms in people proven to have had COVID. And as you can see, the blue dots here shows that probably about 1 in 10 people will still have tiredness, some 6, 8, 10, 12 weeks after. And as you can see, the light blue dots show that after 12 weeks, as opposed to 5, that percentage of people drops, but it does not disappear at all. Absolutely not. And as you can see, all these symptoms, while they do gradually get better, don't just switch off. And 12 weeks is 3 months, 3 months after what for most people is a relatively trivial viral disease. These are big numbers. It's a big problem. I'm sure we'll hear more about that. And certainly Ushin after me will be telling you, I'm sure, telling us a lot about the neuropsychiatric, the neurological manifestations of long COVID. But as I'm sure most of you have seen for yourselves in your patients and your friends, actually, long COVID really is an extraordinarily protean disease that can manifest itself neurologically, cardiovascularly. Generally, I've certainly seen a lot of skin manifestations long COVID, and a lot of people just don't seem to be able to get their breath back either. I'm not going to dwell on this slide. The point about it is that, of course, we are in fact owners of the ACE2 receptor, and this ACE2 receptor, of course, is on endothelium, and we have ACE2 receptors in essentially every end organ you can think of. And because clearly we know that the role of the ACE2 receptor in COVID internalization, you can start to build a picture whereby this is not a virus that attacks the nose or the lungs or the chest. This is a virus that is potentially capable of exerting its influence on any end organ that is subserved by endothelium that has ACE2 receptors. So it maybe is not surprising that long COVID tends to affect and can affect any organ in the body. So let's just pull this one together a bit. And I'm sorry if I'm dwelling on this a bit of a long time, but I continue to believe that in many countries, societally and politically, people are sleepwalking into this disease. It is really, in many ways, compared to the acute devastation in a very few people, usually elderly, usually with comorbidities of acute COVID. The relative contribution of long COVID to society in terms of its level of knowledge and appreciation remains actually really quite small. And I don't quite understand why. I suppose for politicians, it's not a good story. And for members of the public, it's not a good story either. In that chronic fatigue is very often labeled as psychiatric or depressive or people's laziness, and in the very early bad old days of COVID, certainly a lot of doctors considered this disease to be in people's heads. But what they didn't consider is it might be in people's heads for neurochemical reasons, and maybe we'll hear a bit more about that. So this slide really tells it all. So in France, 1 in 10 people were still off work after 2 months. And 45% of the people who had long COVID had to do something about their work commitments because they could not handle them. And at the time the survey was done, 22.3% of them were not working at all because of their chronic health condition of long COVID. This is societally a huge problem. It's economically a huge problem as well. So what are we doing about COVID? Well, this slide probably summarizes it all. It comes, as you can see, from a very good, I think, synthesis of the data by Tim Spector. And you can access this online at the URL I show on this slide. But here's the bottom line. So you get double vaccinated, and the chances are reduced by 80-90% that you're not going to be killed by COVID. And it would appear that that protection extends beyond, the potential threat of variants. And for the moment, at least, even though you are vaccinated with against a Wuhan variant, a Delta variant you will be protected against the Delta variant as well with a Wuhan variant vaccine. The issue is not at all that simple with long COVID, in that whilst on the one hand, it will protect you mostly against infection, not infection, but the hospitalization, death, only approximately 30% of those people who are double vaccinated will be protected against long COVID. And this is also a little appreciated fact. And for many of us who are lucky enough to be healthy, the real problem with COVID is not the acute disease, it's the likelihood of getting long COVID. And I'm not sure that people quite appreciate how important that is. So what do we do about long COVID? Well, the United Kingdom and most countries in the world now have clearly worked out that they need clinics. They need to see people to support them with this condition. But supporting is all that long COVID clinics do now, today. It's physiotherapy, it's CBT, it's encouragement, it's graded exercise, but it is supportive only. There is no clinic that I know of in the world that is offering, if you want, focused, targeted therapy for the condition. And that's a problem. And that's why I think clinics are not enough, you see. So vaccination is not enough. And supportive therapy is not enough. And you can see from this slide on clinics, which was taken from a Nature Medicine article, if you look at all those boxes, they talk about considering things, they talk about following people up, patient advocacy groups, screening for clinical depression and other mental issues. But none of these offer focused, directed therapy against the condition itself. And so what is enough? And that's when we started to think, well, so hang on, what is going on here? Why are these people behaving after a viral infection in this extraordinary way? And we at the physicians clinic had been very interested in actually chronic fatigue syndrome, and we were starting to develop some parameters and some correlates that you can measure in the blood of chronic fatigue syndrome. And therefore, we did a bit of work on the acute immunology of COVID, or the immunology of acute COVID infection. And I'm not going to dwell on this. It is extremely complicated. This Nature Immunology short commentary is, if you really want to get stuck into it, is an excellent place to start. Essentially, what we know is that the people who do badly tend to do badly because they have a CD4 to CD8 imbalance. They fail to suppress very exuberant responses. They're slow in their type 1 gamma interferon responses. And that is probably why. It is probably the lack of suppression within the lung tissue that seems to cause this extraordinary pulmonary failure that is responsible for so much death in the acute phases of acute infection. But what about the longer immune response? Well, there was nothing out there, nothing. And that is where I talked with my colleagues. Dr. Paul Glynn, who is one of the founders of the Physicians Clinic, was seeing patients every day. They were coming in their droves saying, what do I do? Doctors can't help me. I'm told I'm depressed. I really don't know what to do about myself. I used to be so fit and I just cannot work anymore. He was so impressed by that he got together with us, and the three of us work at the Physicians Clinic, and we decided to do something about it. So that's what we did. We got very, very rapid institutional review board approval, and we recruited, in the end, 49 patients. We symptom scored them, and then because there was talk on the streets, literally, and from our patients and patient advocacy groups, that some people were seeing benefit with histamine receptor antagonist treatment, we thought we'd try it. It's as simple as that. And we did this through an institutional review board because these drugs are not licensed for this indication, but we felt that the toxicity profiles of histamine, antihistamines, were so acceptable that we believe that with due patient education about what we were trying to do. We could arrange and agree with them, and some wished to participate and others didn't. So we had 26 people we treated with histamine receptor antagonists and 23 people who got supportive care only, most of them actually because we saw them before there was talk about histamine antagonists, and then we followed them up. Who were our controls? Well, they were our clinical colleagues who had COVID and who just recovered completely. So they had normal mild acute illness and they were completely recovered and asymptomatic. So if you see our long COVID age range, it's pretty impressive. It's between 25 and 65. Our post-COVID controls, these are our clinical colleagues who are completely well, were very well matched. As you can see, they were really well matched in these clinical parameters. I'm not going to bore you with all of them because the publication will be out in a few days. And we did some routine blood tests. It's an interesting blood tube, isn't it? Because it looks like red wine, really. Probably a Burgundy rather than a bottle of blood, but never mind. The point about this is that our patients who had long COVID had never been hospitalized. They had never been that ill. They'd taken a few days off work and they just did not recover. They came to us. We did some routine blood tests and look at these. So we found in full blood counts that only that should actually say 45 out of 49. So we found 4 people whose total or differential blood counts were slightly abnormal. 47 out of 49 had completely normal C-reactive protein, and 44 out of 49 had ESRs less than 15 millimeters an hour. So this tells you something about the demographic we're looking at, but please remember, these are people who come to us because they cannot work, they cannot function, and they have normal routine tests. So we decided to do some not so routine tests. So this is a slide demonstrating, this is a flow cytometric technique that we had designed. Raj Gupta is a clinical hematologist and a flow cytometrist, as I used to be. And so we designed a T-cell subset profile analysis. So you take a normal full blood count, you only need about 500 microliters of blood, and you analyze that by treating with the relevant monoclonal antibodies. You pull out the T-cell compartment, you pull out the CD4 positive from the CD negative T-cell compartment, and then you analyze those for evidence of a second and third set of markers, namely those that differentiate CD4 positive and CD8 positive cells into effector memory as opposed to central memory cells. And we also looked at evidence of whether their T cells had seen antigen before and were either naive and were just waiting to see an antigen, or were experienced and had seen an antigen and reacted to it. We also looked at CD4 and CD8 compartments referred to as TEMRA, which have immunological correlates, which I really probably don't have time to talk about. So what did we find? So here's the bottom line. So on the left-hand side, you will see our normal healthy volunteers and the number of CD4 positive effector memory cells circulating in their blood. That is our normal range. And we'd collected this data over several years before. So this is our calibrated laboratory normal range. We found several things. We found that our asymptomatic patients had slightly less CD4 positive effector memory cells, but this was not significant. But we found that our symptomatic patients had far greater chance of having abnormally low circulating numbers of those cells. And if you plot a receiver operator curve, looking at symptomatic versus, all these analyses were conducted completely blind. What you found is that this particular CD4 positive circulating count of effector memory cells could differentiate between those who had symptoms and those who didn't. Remember, all their other blood tests were totally normal. On the right-hand side, we found something really which we did not expect. We found that even when compared to healthy volunteers, even our asymptomatic patients had lower than expected CD8 positive effector memory cell counts, and that this was much more pronounced in our symptomatic patients. However, we could not, in this very limited cohort, this is a really small observational study, we could not actually ascribe the circulating number of cells to whether they had long COVID or they had just recovered normally. So we thought that was interesting. Just a little word about PD-1. You will know about PD-1 and T cells. This is a molecule that essentially switches T cells off. And it's a receptor, and when it's triggered, it switches T cells off, and those T cells do not kill tumor cells. If you block PD-1, which is an immune checkpoint molecule, then those T cells can expand and start reacting to tumors. And this is how this increasing world of immunotherapy is developing. And most immunotherapeutic agents at the moment target immune checkpoint molecules such as this. CD28 does quite the contrary, in that if you tickle up CD28 on a T cell when it sees an antigen, that will increase its chances of, rather than dying off, proliferating and differentiating, and it will also increase its effective T cell functions. Clearly, it's more complicated than that, but those are the principles. And so we thought we'd have a look at the T cell landscapes in our normally recovered and long COVID sufferers. So what you've got here on the left are the checkpoint inhibitor density, molecular density in the circulating cells of our patients. And you can see they're healthy volunteers. And what we found was that for the CD4 positive cells anyway, it appeared that both symptomatic and asymptomatic patients had higher numbers of T cells displaying a checkpoint inhibitor. And if you looked at the CD8 positive cells, this was far more highly prevalent in symptomatic patients. So symptomatic patients have got more CD8 positive cells that are circulating that actually are expressing this checkpoint inhibitor. And the point is, if you express a checkpoint inhibitor and that you have a ligand to it, then in theory, you should be switching those CD8 positive cells out. The CD28 co-stimulator molecule information is important, in that the big change we saw is that if you'd recovered, you had a higher density of CD28 on your CD4 positive and CD8 positive cells. So these are cells that are more, if you want, in the groove when it comes to reacting to antigen stimulation. And for all we know, it's a proposal and it's a hypothesis to test. What you see in the CD4 positive, CD28 positive cells here is a healthy, normal response to virus recovery, which we did not see in the symptomatic group to anywhere the same degree. So you're going to ask, well, what happened to the people we gave histamine receptor blockade to? So we gave two antihistamines, one against H1 and one against H2, and we gave them together for 8 weeks or more. And this slide shows symptom burden per patient on average for those before they got a histamine receptor antagonist and after. And as you can see, there's a highly significant drop in the average symptom burden in those people who were given these antagonists. The person, Dr. Tamasebi, who actually assessed them, did not know whether they were in the control group or not. So they were completely blinded to whether they'd been treated or not. And on the right-hand side, this is another way of demonstrating. So if you get more symptoms, we class those as 1. If you're better, you class them as 0 or -1. And as you can see here, what we found was that the untreated group really did not change in their symptom burden, whereas the HRA-treated group displayed significantly less symptoms after 8 weeks. Another thing to say is this was not an instant effect. It took several weeks. So you're going to say, well, it's antihistamines, they stop you sneezing. Well, it's not quite right. Human T cells have got H1 and H2 receptors, and famotidine, which is an H2 receptor blocker that we used, we now know is capable of desensitizing T cells via beta-arrestin blockade. And this drug on the left, which is available over the counter in most countries, but not the UK, is used as a stomach ulcer medicine. It's very, very, very safe, but it also happens to work on beta-arrestin. And beta-arrestin is involved in G protein coupled receptor pathways and is absolutely fundamental to lymphocyte signaling. I'm just about finished now. So just for 1 minute, Charles Bangham, who's a fellow of the Royal Society and a very, very eminent professor of immunology at Imperial, this was in February, he actually put a blog out saying, well, what do we know? And he said, to really understand what's going on, we really need to find an underlying mechanism for why or how this virus is causing such long-lasting symptoms. Well, ladies and gentlemen, this is a really small observation study, but it was blinded. Of course, it doesn't prove anything, but we believe it sets the trajectory and the pathway for future work that needs to be done now. Namely, what we need are properly constructed future randomized controlled trials of these antihistamines in long COVID. It may be that actually our T-cell immunophenotyping test is good enough to be able to monitor these people's progress, let alone diagnose them. Because there may be some people who are just clinically depressed who think they've got long COVID. It may be that this test is an objective assessment of that when all other clinical laboratory tests are completely normal. I should also point out that some of our patients had actually been ill for over 400 days. And I should remind you that in those T-cell plots, abnormalities were seen up to and beyond 400 days, including the smaller abnormalities in our COVID recovered group. We have no idea about why that is and why these abnormalities persist as long as they do, but maybe this work is setting some sort of direction. And clearly what we want to do is some single cell analysis and proteomics work to drill down a bit more carefully on why we're getting these circulating changes in numbers. So I just finished by acknowledging, first of all, Paul Glynn, because he's the real driver behind this. He saw the patients and we decided to act. We acted and Raj Gupta is our hematology colleague. We decided to act and act quickly, and we got this study up and running in less than 2 months. And where did we get the money from? We got the money from charitable donors. This was not through a big grant. And we should obviously thank both our patients and our control COVID colleagues, and also HCA, who were very happy to take on the institutional review ethical approval board business for us. So on that note, I think I shall finish there. I can see we've got some questions coming in, but I think in view of the changed program, the right thing to do now is for me to hand over to my colleague Ünal Çevik. I hope that's about right. So Isin is a neurologist and a neuroscientist in Ankara and in Turkey. She has a particular interest in pain syndromes. And it's with very great pleasure that I will now hand over to Isin. Thank you very much.
Thank you so much, Dr. Vanya Gant. And now I'll be talking about clinical aspects of long COVID specified on neuropsychiatric symptoms. So we know that we are not in the beginning. Actually, as Winston Churchill said, we are just in the beginning of the end. So we have so much things to go on, learning and sharing with each other. Viral neuroinvasion can have some consequences in central nervous system, such as viral encephalitis is an acute consequences. Subacute could be post-infectious acute disseminated encephalomyelitis, and delayed consequences such as SSPE or von Economo encephalitis lethargica, or any kind of infections which can be related with demyelination disorders like MS or Alzheimer's disease. So we know that virus can actually induce neurological symptoms, not directly, but also due to indirectly issues such as hypoxic ischemic injury, stroke, toxic metabolic change, cytokine storming, or molecular mimicry against neuronal, glial, or peripheral nerve cells. When we think of all the respiratory infections, we know that they are entering our body through respiratory tract. And also we have shown that the coronavirus, human coronavirus OC43, can also be introduced to the CNS through intranasal injection. This is a mice, and after intranasal injection of the virus, we were able to detect the virus within the olfactory bulbus and also within the brainstem. So this is the principal route of infection through olfactory route. Besides, axonal transport or neuron to neuron transport and propagation is also another way of the virus to get into the central nervous system. As seen here, similar model is used. The mice is injected intranasally with the virus, and the researchers were able to detect these virus information within the CNS. So emerging data is coming and the potential mechanisms how COVID-19 affects neurological manifestations. So we know that the route could be through the olfactory route. It could be also through cranial nerves such as the trigeminal nerve, the glossopharyngeal nerve, the vagus, or it could be also due to hematogenous routes. So after the virus has entered to our body, we may have some manifestations within the CNS. Mainly the cerebrovascular manifestations are called as stroke. They could be either ischemic or hemorrhagic. And we know that they're partially due to the systemic inflammatory cytokines and thromboembolic hypercoagulability states, and also impaired gas exchange due to severe COVID pulmonary disease. The brain is susceptible to low oxygen saturation, and this hypoxia may deteriorate the functions of the cortex as well. And when there is a systemic cytokine storm, we know that the blood-brain barrier may be disturbed, and these cytokines can enter the CNS, so there is a neuroinflammation. Also, the autoantibody production against neural antigens crossing blood-brain barrier can damage the nerves and the glia, and cell dysfunction and death and further inflammation may be related, as we see in acute encephalitis or ADEM patients. What about COVID-19? Can it also enter through olfactory route? Is there any evidence? Yes. This study shows that SARS-CoV-2 RNA copies can be detected by histomorphological, ultrastructural, and molecular analysis, that all the olfactory mucosa, olfactory tubercle, and trigeminal ganglia, medulla oblongata, and also brainstem and cerebellum can be produced by this virus RNA copies. And how can we detect, is there any relation with the disease severity or disease duration? Yes, there is a inverse correlation. In the first few days of the infection, we can detect more RNAs, but when the disease progresses, it's hard to detect these RNAs. And also with the immunohistochemistry or in situ hybridization or electron microscopy studies, were able to detect SARS-CoV-2 proteins like spike proteins or the virus particles from olfactory mucosa. So we know that there is an invasion of the virus to our olfactory mucosa. And here is the cells that are infected with SARS-CoV virus. This is the spike protein. And when you merge it with the neurons, there is intracytoplasmic inclusions within the nerves and also the non-neuronal cells. So what about the brain inside the deeper elements? We know that there are signs of microthromboembolic events, and this could be shown in thalamus. This is a small vessel with a microthrombi, and here is the section from medulla oblongata, and this is a section from the pons. We can see that the virus S protein antibodies, which are stained with brown, can be detected in the brainstem and also within the thalamus. How about the cerebrospinal fluid in COVID patients? Can we detect this virus with PCR? Actually, we are not as good as defining CSF PCR positive patients. The number of the percentage is only 6%. The patients who have tested for PCR, and the antibody results in the CSF for SARS-CoV-2 is only 12%. So we can say that detection of SARS-CoV-2 in CSF via PCR or antibody synthesis appears to be rare. But we know that these patients have actually very profound CNS symptoms such as encephalopathy, seizures, or coma. And the CSF analysis shows that these patients do not have so many cells within the CSF. The white blood cell counts only 1 or 5 cells per microliter. And the protein levels in the CSF of these patients are not so high. It's between 15 to 60. But what is important is the biomarkers in the CSF of these patients are really informative. Among the almost 80% of the patients had elevation of at least one CSF biomarker. These could be like interleukin 6, interleukin 8, 10, interferons, alpha, or tau proteins, or 1433. There are so many biomarkers that can be detected in COVID patients' CSF. So why aren't we able to detect virus in the CSF? Why are the PCRs so negative? This could be due to the change over the course of patient's illness. It could be due to CSF PCR is not highest when it's obtained 5 days after onset of the neurological symptoms. And when the course of the disease changes, we may not be able to detect it. Or the virus is mainly cell-bound, so it spreads from cell to cell. It's not easy to detect in the CSF. Also, the testing method or the presence of low concentrations of endonucleosis or exonucleosis within the CSF may inhibit us to detect CSF PCRs to be positive. This is a patient which has been shown that SARS coronavirus 2 can invade central nervous system. Here you can see that on electron microscopy, 80 to 110 nanometers viral particles in frontal lobe from the brain sections. And also they were able to demonstrate the presence of SARS-CoV-2 RT-PCR assays. These were especially within the endothelial cells. So the authors think that the hematogenous route is the most likely pathway for COVID-19 to enter the brain. There are so many other neuropathological reports for COVID-19 patients. These patients can be from 1 patient to 23 patients. There are so many series, like 18, 17 patient series. And the authors usually find activated microglial cells within these brains, perivascular T lymphocyte infiltrations, and they can see some signs of ischemic lesions. So this study comes from Germany. And they have investigated 43 patients post-mortem case series, and they saw that the brainstem, cerebellum, and the meningeal cytotoxic T lymphocyte infiltration was seen in almost 80% patients. So the neuroinflammatory change in the brainstem is the most common finding, and they think that COVID-19 related neurological symptoms are most likely to be immune mediated. What are the COVID-19 symptoms prevalences? In neurological perspective, we see altered mental status, almost 30%. We have headaches, almost 40%, neuropathic pain, anosmia, and loss of taste and smell, stroke, GBS, dysautonomia, and meningitis, encephalitis. This is a nice surveillance study from United Kingdom, and they have investigated 153 patients, and they were able to see that the mental status change was present in almost 60% of the COVID-19 positive patients. And interestingly, half of the patients were younger than 60 years. This is interesting because we know that when the age increases, the mental status changes are more likely to occur in ICU patients or any critically ill patients. But this data is giving a sign for us that even patients younger than 60 years may face with neuropsychiatric disorders. So what is post-viral fatigue syndromes? It has been almost recognized in the late 1980s. The prominent symptom is severe muscle fatigability. However, the patients have some secondary symptoms, such as aching of muscles, disequilibrium, which means dizziness, and some psychiatric manifestations. They may also have some cognitive alterations. They may complain of unrefreshing sleep and post-exertional malaise are also common symptoms. So chronologically, these chronically fatiguing syndromes related with the infectious diseases have been described in poliovirus, after brucella, after Spanish influenza pandemic in 1988, and these patients were presented as the sleepy sickness, encephalitis lethargica patients, which also developed some post-infectious Parkinsonism, even 1 or 2 years after the pandemic. H1N1 influenza also is reported to have chronic fatigue syndromes, and Epstein-Barr virus is also the other virus that we know. Coronavirus infections are also reported to have post-viral fatigue syndrome, especially the SARS survivors are known to have non-specific pain, fatigue, and mood alterations. However, now we also know that the COVID-19 long haulers, the long COVID, also describe fatigue, headache, chest pain, musculoskeletal pain, cognitive alterations, autonomic symptoms, and sleep disturbances. So, according to the National Academy of Medicine, there are some criteria, the case definition for myalgic encephalomyelitis and chronic fatigue syndrome, that the substantial impairment in the ability to function at home or work lasting more than 6 months, unrefreshing sleep, post-exertional malaise, and also cognitive impairment or autonomic symptoms such as orthostatic intolerance are reported in these patients. This syndrome can be due to the central nervous system abnormalities. It could be due to autonomic nervous system dysfunction, and it could be due to immune dysregulation, disordered energy metabolism, which is the mitochondria, and the redox imbalance. So let's come to long COVID. We come up with Dr. Paul Garner, who is a professor of infectious diseases in tropical medicine, discussed that he was experiencing of 6 weeks of long COVID symptoms, such as he was feeling that a roller coaster of ill health, extreme emotions, and utter exhaustion. This is the first description in medical literature from a person who really had long COVID symptoms. And then after, Dr. Eliza Pirigo also described that she was suffering from long COVID, and she was the first person to use long COVID in our literature. So NICE has now declared that COVID-19 has long-term effects, and if the symptoms after COVID continue for more than 12 weeks and not explained by an alternative diagnosis, these patients should be classified as post-COVID-19 syndrome. And after that, we see that CDC also have announced the interim guidance, but they use four or more weeks after infection of having some physical and mental health consequences. And lastly, in January 2021, World Health Organization updated the clinical management of COVID-19 patients, because we know that some patients report persistent neurological manifestations, either mild or more severe conditions. Mild symptoms are such as headache, hyposmia, loss of taste and smell, and fatigue. And the more severe conditions are cognitive impairment, sleep disorders, pain, and GBS. So the clinical course of COVID is expected to recover between 2 to 6 weeks. However, 10 to 15 of the cases progress to severe disease. And we know that 30% of the COVID-19 patients served still had persistent symptoms after 9 months, which is really a long time. So what are the long-term effects of COVID-19? It has been addressed that 80% of the patients usually describe at least one symptom, but some of them may describe more than one symptom. The most frequent symptom is fatigue, headache, and memory loss. We also have loss of taste and loss of smell sensations lasting more than 3 months. We might have some hearing loss, chest pain, joint pain, anxiety, depression, sleep disorders, and post-traumatic stress disorders or obsessive-compulsive disorders. So what makes a patient to have a long COVID? What are the risk factors? It has been proposed that if the initial 5 symptoms are present in a patient, then this patient might be a person for long COVID. If the initial disease severity is high, if the patient is having a female sex, if the patient has elevated levels of D-dimer, CRP, or low lymphocyte counts, and if the patient already have pre-existing comorbidity, prior psychiatric disorder, old age, or increased levels of interleukin-6, procalcitonin, troponin, BUN, and neutrophil counts, then these patients might be more prone for long COVID, which means that long-term tissue damage and unresolved inflammation could be the pathophysiological mechanisms under these long COVID symptoms. And in this cohort study from China, we see that COVID-19 patients were followed up for 6 months, and the median time follow-up were around 186 days, and fatigue or muscle weakness were the most reported symptoms. And sleep disorders, anxiety, depression were also reported in these patients. So at 6 months after acute infection, COVID-19 survivors were mainly troubled with fatigue or muscle weakness, sleep difficulties, and anxiety and depression. In a prospective study of long-term outcomes among hospitalized COVID-19 patients with or without neurological complications have been described in 606 patients, and the authors concluded that both groups of patients had high rates of cognitive impairment, approaching or exceeding for more than 50% of the patients at 6 months. This is a really, really high number. Patients with neurological complications had worse 6-month functional outcomes. Anxiety, depression, fatigue, sleep disorders were also reported by these survivors. So this is really a fascinating information. Post-acute COVID-19 syndrome negatively impacts health and well-being despite less severe acute infection. This is another fascinating information because we thought that if a patient has a severe infection, he would more likely to have long COVID. But even though less severe, these 84 patients recovering from COVID-19 expressed fatigue, loss of concentration, which is 74%, which is really, really high, weakness, headache, and dizziness. These are the symptoms that were present in the acute phase. And I would like to say that there are some symptoms which are not described in the acute phase, but when the patient persists some symptoms, some additional persistent symptoms are also added, such as dizziness, irregular heartbeat, irregular body temperature, memory problems, and so on. So these symptoms may be introduced in the later phases of long COVID. This is a proposal from Mayo Clinic, and they try to develop a criteria for post-COVID syndrome. And they say that pain could be very high in these patients, like 90%, fatigue 74%, dyspnea 43%, and orthostatic intolerance. So central sensitization symptoms are referred to post-COVID syndrome, especially painful conditions, constitutional, cardiac, respiratory, gastrointestinal, musculoskeletal, and neurological symptoms has to be present. 2 of 6 are the core systems which are included in the criteria. Functional autoantibodies against G protein coupled receptors in patients with persistent long COVID symptoms are another important information that we can face up with. This study has investigated 31 patients, and most of them, 29 patients, had symptoms of neurological origin, and they were able to show that autoantibodies directed to beta adrenoreceptors, either beta 2 or alpha 1, angiotensin 2 receptor antibodies, nociceptive-like opioid receptor antibodies, muscarinic receptor antibodies, MAS and ETA receptors antibodies were detected in these patients who were having some symptoms of long COVID. So chronic post-COVID syndrome and chronic fatigue syndrome have some similar aspects. So is there any role to provide a therapeutic option using apheresis? This report comes from 3 post-COVID-19 patients, and after extracorporeal apheresis, all 3 patients could significantly reduce the level of autoantibodies, and their symptoms of chronic fatigue were elevated by this therapy. So taking of these autoantibodies could favor these patients, and this could be a therapeutic option in long COVID patients. So what about long COVID headache? We know that headache could be the initial symptom of acute COVID-19 infection. And however, long COVID headache is another problem coming into our daily life. This headache could be spread throughout the skull, and the patients describe feeling of constriction and weight at the top of their head. And if the patient has already been suffering from migraine, after COVID-19, these patients say that they are having multiple of crises of migraine attacks. They have worsening, they have chronification of the pre-existing migraine. We may assume that innate immune signaling and activation of inflammasomes could be implicated in the pathogenesis, and also sleep difficulties could be making these symptoms worse. So headache as an acute and post-COVID-19 symptoms in COVID-19 survivors have shown that in the acute phase, we may be facing around 60%, but in the chronic phase, in the late phases, the chronic pain syndrome is present almost at 10% of the patients after 180 days. The prevalence of post-COVID headache range from 8 to 15 during the first 6 months after infection. Although decreasing, still present. Headache with SARS-CoV-2 infection, is it a matter that we should worry? Yes, because these are more intense in women. These are in generally younger patients in productive life, and they have high frequency of fever. And this kind of central sensitization may be devastating and having their quality of life decrease. And these patients may have predisposing factors and pre-existing primary headache syndromes. What about pain syndromes implicated with COVID-19? We know that this virus can directly target sensory neurons in the dorsal root ganglia. And this virus is very important in producing systemic inflammation. The systemic inflammation can make the nerves hyperexcitable, and also it can cause some long-lasting effects like central and peripheral sensitization. How about fibromyalgia? We know that COVID-19 syndrome spectrum could be also a part of fibromyalgia. These patients might have those kind of symptoms. Everywhere is aching. And in a survey, they have found that 30% of the long COVID patients satisfied the criteria for fibromyalgia. And who were more susceptible for fibromyalgia associated with COVID-19? The male gender and pre-existing obesity were the most reported risk factors for post-COVID fibromyalgia. And here is another study showing that long COVID patients have small fiber neuropathy. In corneal confocal microscopies, in the study, here is the healthy control showing very nice small fibers. However, if the patient has long COVID, then dendritic cells are increased, and we don't see these long, healthy nerve fibers anymore. So there's a loss of fiber, and there's an increased dendritic cells in long COVID survivors. This is a patient only having COVID-19 without long COVID symptoms. So it is still less than the healthy control, but it is not as bad as long COVID patient. So there are some autonomic dysfunctions associated with long COVID. These are orthostatic headache, lightheadedness, syncope, hyperhidrosis, burning pain. And if we test them with either quantitative pseudomotor axon reflex, thermoregulatory sweat test, or a head-up tilt test, we are able to demonstrate these differences. But the autonomic testings are mild in most cases. However, the symptoms are really very prevalent. Autonomic dysfunction in long COVID could be treated by education, by exercise, by fluid and salt repletion, compression garments, and pharmacological treatments could be option to relieve these symptoms in these patients. And autonomic symptoms are usually associated with orthostatic hypotension or postural tachycardia syndrome, and higher COMPASS scores reported in neurological symptoms correlate with these patients. If the patient has neurological symptom, then the COMPASS score is high and orthostatic symptoms are reported more. We may hypothesize that as the virus likes to go to the brainstem, if the severity of the COVID-19 damage increases, then the failure and breakdown of the brainstem functions might be more severe. However, in less severe damage, chronic or persistent dysfunction could be related to chronic pain, chronic migraine, CFS syndrome, or long COVID. Long COVID and the brain network, we know that olfactory function is important in memories. This is Marcel Proust, in his writings, we read that when he dips his Madeline in the tea, then he smells and tastes, and then suddenly he goes back to his childhood memories. So olfactory information is linked to hippocampus, to amygdala, and this is why memory complaints in 80% of patients with olfactory loss is more prominent than the patients who do not have olfactory loss. Similar information has been given in Alzheimer's disease and Parkinson's disease. So olfactory function is important, and it's also known that COVID-19 patients usually have loss of smell, and they also complain in the long COVID terms with loss of memories. And they also have some dysfunctions in mood. So Alzheimer's like remodeling of neuronal ryanodine receptor in COVID-19 has been also shown. Neuropathological pathways activated downstream of leaky ryanodine channels in Alzheimer's disease patients were also activated in COVID-19 patients. This may be a connection with memory loss. What is brain fog? We have actually known this, and this is not a medical or scientific term. It has been used by individuals to describe how they feel when their thinking is sluggish, fuzzy, or not sharp. And now COVID-19 is also, the patients also describe some problems of focusing, some problems of concentrating, finding words, trouble with daily thinking, short-term memory loss, and they also describe some behavioral changes. And this is now termed as COVID-19 brain fog. So what can we do for this? We can perform aerobic exercises, eat Mediterranean style, avoid alcohol, drug, participate in social activities, and sleep well in order to come up with this brain fog problems. When the COVID-19 patients are examined, followed up for 3 months, this MRI study shows that microstructural changes are also evident in these patients. And these changes correlate with memory loss and also with smell loss. The changes are usually seen in olfactory cortexes, hippocampus, insula, Rolandic operculum, and also the cingulate gyrus. Long COVID complaints of brain fog patient, there is 2 patients, and these 2 patients had some cognitive dysfunctions, and they were investigated using PET study, and these authors reported that the cingulate cortex were hypoactive in these 2 patients. So anterior and posterior cingulate cortex are implicated in emotions, memory, depression, and decision action. And these parts of the brain are hypoactive. So these symptoms could be related neuroanatomically to this cingulate dysfunction. So what about another study investigating the cerebral network in COVID-19 related encephalopathy in 7 patients show us that in the acute phase, these regions are hypoactive. 1 month later, it is a little bit less, but still hypoactive. And even after 6 months after COVID-19 onset, we can see that the same regions, but they were less extended hypometabolism found in bilateral prefrontal cortex, insula, and cingulate cortexes. And in this patients with long COVID, this is a study coming from 35 patients with long COVID compared to the healthy control. And again, the same similar areas are shown to be hypometabolism, cerebral hypometabolism was detected in these patients' brains. Cognitive impairment and altered cerebral glucose metabolism in the subacute stage of COVID-19 is shown in these patients, and the similar results are also compatible with the previous results. So post-mortem, they also had one patient examined with biopsy, and they show that microglial activation within the white matter was prominent, but the hypometabolism in the frontoparietal cortex could be a removed process due to brainstem or white matter pathology. So they were happy to announce that these neurological deteriorations could be reversible, which is a good news. And here is another PET study showing that in patients with acute encephalomyelitis, autoimmune encephalomyelitis, and also in subacute COVID-19, these areas are similarly hypermetabolic, but in the long COVID terms, these areas turn out to be hypometabolisms. This is another study showing that pediatric cases also show the similar areas of hypometabolisms regardless of age and initial severity of COVID-19. We know that patients also describe long COVID symptoms. So what about dementia and COVID-19? Unfortunately, there is a bidirectional attraction. COVID-19 versus dementia symptoms, dementia versus COVID-19 acute infection. So we should be very careful in treating these patients. And Parkinson's disease also have a bidirectional effect. When the Parkinson's disease patients faced with COVID-19, they have worsening of motor functions, and also they have described non-motor symptoms like long COVID symptoms. So we should be very careful in managing these patients. And the psychiatric phase of COVID-19 is also very important because the similar brain pathways are affected, and depressive disorders, bipolar psychosis, obsessive compulsive disorders, and post-traumatic stress disorders are described in COVID-19 patients. And this depression could be either to social pathological factors, social quarantine, economic problems, but also it could be due to stress reaction to COVID-19, HPA axis. Inflammation is very important, mitochondrial damage, and also malnutrition could make these depressive symptoms worse. There is a bidirectional association between COVID-19 and psychiatric disorders, and like anxiety, insomnia, and dementia has been increased after COVID-19. And these patients have a risk of psychiatric sequelae that this diagnosis should not be underestimated. So I think more research is needed to examine the long-term consequences of COVID-19, and both the World Health, all institutes are trying to make research opportunities to reveal, to understand what's going on with long COVID. And we will be understanding more and more when we get more data. Thank you so much for listening me.
Well, Isin, what can I say apart from çok teşekkürler?
Thank you.
That was quite extraordinary, not particularly whirlwind, but fabulously detailed tour of the bottom line is the increasing evidence that there are mechanistic clues to the pathways, whereby all these patients who not long ago might have been considered to have been depressed and given amitriptyline, actually have real molecularly defined conditions, I suppose, between the immunology and between the MRI and all the other things you've talked about so brilliantly. That's going to give us a lot to talk about. So without further ado, thank you very much. Without further ado, I will ask Dr. Levy to give his presentation. Dr. Levy hails from Hadassah and the Hebrew University, and he clearly has got a personal long interest in COVID, a long interest and a long COVID clinic. And without further ado, I think we should now proceed to Dr. Levy's talk. Thank you very much.
Good afternoon. I would like to thank the organizing committee for giving me the opportunity to give this talk. Really, long COVID bothers us now for almost 2 years. And I think it's a very good idea to give also the clinical experience. And I would love to share our clinical experience here in Sheba Medical Center in Israel. So, there are many names for this phenomenon, like long COVID, post-COVID, post-acute COVID, long haulers. But, everyone who comes into this room just tells me, don't call us recovering from COVID, because really, if we still have symptoms after 2, 3, and 6 months, you cannot call us recovering. It all began about almost 2 years ago, at May 2020, when a colleague of mine, which ran together with me half marathon just before COVID, came into my office and asked me, I had COVID during March 2020, and now we are 2 months later, and I cannot really walk. I cannot run. You remember, we did the marathon. I was in excellent shape. And now, even if I'm going like 100, 200 meters, I feel my breath. And I did chest x-ray. I did all the examinations. Everything is normal. So we did the 6 minutes gait test. And it was abnormal because usually you expect after 6 minutes to see that the pulse is going up. And she really tries to go fast. But nothing happens with the pulse after 6 minutes. Another phenomenon that we saw is 2 other women. One is a lawyer, the other one works in a library, and also they came and started to complain about the memory, about the concentration, and we did the MOCA test, and as you can see here, it's in Hebrew. I don't expect you to understand the language, but everyone knows how to read the clock. And as you can see, both of them really intelligent, educated women, and all of a sudden they couldn't copy the cube or do the clock test. So we started to think there is something here that we must really explore deeply. Then at that time, we already knew what happens just before symptoms of COVID, acute COVID appear. We knew what happens during the acute COVID. We started to understand that cytokine storm and all the things that everyone now thinks, but we didn't have any idea what happens here. Like after people should be recovering and feel well, like after every other viral infection. So we opened our post-acute COVID clinic and did a clinical study, because really nobody could tell us what's happening, not from China. We had a lot of discussions with them, not from Italy. So first thing, we had to define who are we seeing in the clinic and who are we including in our studies. Our definition was people with ongoing symptomatic COVID, for people who still have symptoms between 4 and 12 weeks after the start of acute symptoms, or post-COVID-19 syndrome for people who still have symptoms for more than 12 weeks after the start of acute symptoms. So actually, we could divide it into early after COVID or late after COVID. And then for the first 200 patients that we saw in the clinic, we did in-depth assessment, which included medical history and acute COVID-19 symptoms and severity, current symptoms checklist, the SF36 and PROMIS-10, the PCL5 for PTSD, sleep quality questionnaires, PHQ for depression, another questionnaire for ADHD, and of course, all the lab and imaging studies. We included only patients which were not in ICU or on ECMO or ventilated, because those patients have many complications after the release, and we felt that we will not be able to tell what's from the COVID itself and what's from the fact that they were in a severe condition in the ICU. So in the first 200 patients, 8 patients were not included because 2 refused to answer all those questionnaires, 3 did not have enough information, and 3 were counted twice. So we included in these 214 which had severe or critical disease, but still were not on ECMO or ventilated, and 178 patients with mild or moderate disease. The socio-demographic characteristics of those patients, you see that their age, average age was 43, but the range was from 18 to 81. Most of them were females. Most of them were born in Israel. We had a few which were born in the former USSR, some in Ethiopia. Ethnically, about a third of them were what we call Ashkenazi Jews, which means they came from Europe. The third were coming from Middle East and North Africa. And then we saw also mixed and Arabs, etc. Regarding the outcome, we divided those patients into the 2 groups, the early after COVID and the late after COVID. And what we saw is that the most common symptoms were severe fatigue, which were in more than half of the patients, and there was no difference between the groups. Memory impairment, which was in about a quarter of the patients. Depression, which was more common in the early COVID, 27% compared to 12% in the late COVID. Anxiety, it was about the same. Anosmia and agusia was about in 1/5 of the patients, hair loss in about a third or a quarter, difficulty in going back to physical activity. Actually, this was one of the things which really bothers the patients the most. And you see that in early, it was in a third of the patient and in a quarter in the late, but it was not statistically different. Sleep disorders, the same percentage. A MOCA test, which was impaired, was in 36% and in 56%, and it's a huge percentage to see, because all of those patients, we assumed that the MOCA before the COVID was normal, but it's an assumption. This is one of the limitations of this so-called study. When we did a multivariate analysis to see what could predict persistent symptoms, actually we find that the age and the delta time since the acute COVID up to the visit in the clinic was not a factor, but being female and the number of symptoms in acute disease actually were the most predictive for symptomatic late COVID. And I can already tell you that in all the studies that were done later all over the world, those were factors which were repeated in all those studies. In those times, we really started to ask ourselves, because we did a lot of cardiological and pulmonological and immunological studies, and we couldn't find something objective. So there were a lot of us which asked themselves, is it a real problem? Or is it maybe something psychological? or is it something sociological? So how can we know if something, a symptom, is a real symptom, so-called, or something psychological? So if there is an established biological basis, then for sure it's for real, but here we could not find the biological basis which is common for all the patients. If there is an established theory or concept of proof, also it's a good reason to say that it's real. Here we couldn't find this. If there are valid epidemiological associations, then it helps us. It does not explain, but it may help us to understand that there is a problem, and now we have to understand what makes this problem. But at that time, there were no epidemiological associations yet, but only very small and sparse studies. And another thing, if repeated in the same way in different geographical areas, cultures, etc., then we can say that probably it's a real problem, because you would expect that different cultures will have different symptoms if it's psychological only. And here we could already started to say that in all of the places, all of geographical places, all of cultures that this was examined, they all complained about the same symptoms: difficult of going back to physical activity, fatigue, headache, and memory loss. And we started to really look at other studies, and probably most of you know those studies, like one of the first one. It was presented by Tenford in the MMWR in July 2020. And also you can see there that he examined post-COVID patients, and he saw that 65% returned to health within a median of 7 days after testing, but 35% had not returned to usual health after 2 to 3 weeks. And also the same complaints as we saw, like fatigue, cough, headache, body aches, loss of taste and smell, etc. Then another study by Gertz, which was published 2 months later in August 2020, you can see again that many of the patients had symptoms long after they should have been recovered from the acute COVID, and many of them had more than 6 to 10 symptoms. And when you're looking at the symptoms, it repeats itself again: fatigue, dyspnea, headache, chest tightness, cough, muscle pain, etc., etc. And really, if you take all those studies and put them one near another, you see that fatigue and difficult of going back to physical activity and memory and concentration difficulties were repeating in all the studies. Another study, which was presented later in February 2021, again showed similar things after 30 days and 60 days after recovery. And here you can see the patients that were included in the symptoms. Just a moment. And you see that dyspnea, shortness of breath, chest pain, again, repeated themselves. I don't want to really bother you with many of the studies which show the same. But then we started to ask ourselves, so how long can it take? What is the pattern? How can we predict it? And we saw that we understand actually nothing about it. So we did another study. And this time it was an online study, a survey, which was based on immediate messaging system, SMS. And actually what we studied here was the demographic, including age, education, marital status, country of origin, prior medical history, especially BMI, prior diagnosis, medications, symptoms of acute phase, hospitalization and treatment. And then we asked, how do you feel or function now compared to pre-COVID time? What are your long COVID symptoms? And we emphasized on work days lost, health service, and the health services utilization. Actually, we had two groups of patients. One was healthcare workers. We had more than 800 of them. And then more than 1,500 patients which were hospitalized or came to the emergency department because of a positive PCR. For the online survey, we sent the SMS to 243 healthcare workers and 3171 patients with a positive PCR, and 614 respond to our SMS. The median age was 15, and it was about the same between patients and healthcare workers. Females were 43% among the patients and 77% among the healthcare workers. This is probably because we have many nurses which responded to our questionnaire. 72% were Israeli born. The medical background was about the same in both groups, only malignancy was a little more in patients, 11%. Immunosuppressed patients was the same in the two groups. Diabetes was more common among patients, 18%, in healthcare workers, 3% only. Hypertension, 25% in patients and 8% in healthcare workers. Rheumatic disease was the same, as well as anxiety and depression. And when you asked about general health condition, 38% in the patients said it's good, and as among healthcare workers, 69% said they had a good health, general health situation. Then we asked about the symptomatic COVID during the acute COVID, and here there was not also a different statistical difference. Most of the patients, about 59% and 38%, had fever, cough, throat pain. You can see in about a fifth of the patients, dyspnea, 67% in the patients, 84% in the healthcare workers, myalgia, about half of the patient, weakness, of course, which is one very important symptom of acute COVID, anosmia, 37 and 52%. About treatment in acute COVID, 18% of the patients received steroids, 13% remdesivir, and much less of the healthcare workers received therapy. 17% of the patients got anticoagulation. By the way, you see those percent and you understand that it was really patients with mild disease, because patients with moderate or severe disease, they all received steroids, remdesivir, and anticoagulation. And 41% didn't get any treatment at all in the patients, and healthcare workers, 78% didn't get treatment. 5% of the healthcare workers were hospitalized, whereas 52% among the patients. Now we asked when was your acute COVID? So you see that the fifth of the patient, the acute COVID was 1 to 3% before the questionnaire, 38% it was 3 to 6 months before, 23% it was 6 to 9 months before, and 18% more than 9 months before the questionnaire was given. Here you can see again, from the 614 responses, 71 healthcare workers with long COVID and 140 patients with long COVID among the patients. The prevalence symptoms of long COVID 1 to 12 months after diagnosis, again, fatigue was the most common, 36%, exercise intolerance, 35%, memory disturbance, 31%, and then you can see all the rest: myalgia, depression, headache, anxiety, alopecia, angina, anosmia, cough, and dermatological problems. We compared between the COVID-19 patients with long COVID symptoms and symptoms-free patients to see if there is something that we can predict which of the patients will suffer from long COVID. And you see that the age was not different between the two groups. There were more females in the long COVID group. There was not a difference between healthcare workers and patients between the two groups. And the length of time, delta, between the acute COVID and the present symptoms, also there was not significant difference, and no difference in those who were born in Israel or other places or the education. And regarding the medical history, there was a difference in the BMI when the BMI of long COVID patients was higher compared to those with not long COVID. And there were more lung disease in patients with long COVID compared to those with did not have long COVID. And chronically treatment with all different kind of drugs. We didn't differentiate the kind of drugs. Also, it was more common among long COVID patients compared to those which did not suffer long COVID. In all other parameters, there was no difference. So then we did a multivariate analysis to see which of all those parameters could predict long COVID. And we saw that after taking everything else into account, female gender, being healthcare workers, having a higher BMI and having lung disease, and being symptomatic during the acute COVID, actually it was the only parameters which could predict a long COVID in our study. The average loss of work days was 8.9. For those who suffered long COVID, it was 3 times more than those who did not have long COVID. 19% did not return to work at all. 5% did not return to work due to the illness, because others may not return to work because of other things. 21% required additional treatment, 7% physiotherapy, 2% occupational therapy, 3% respiratory therapists, 6% psychologists, and 8% other, including alternative medicine. So to sum up this work, we had 614 responders, 33% declared they feel worse than did before COVID infection. Most frequent symptoms were fatigue, exercise intolerance, and memory deficits. There was a variable change in time, and patients at risk for long COVID symptoms were female, those with lung disease, those who were symptomatic during the acute COVID, and those with a higher BMI. Healthcare workers were relatively protected. And then we tried to see if there are some other works that did something similar, and they could help us predict who will have the long COVID. And we found this work in Nature Medicines, Attributes and Predictors for Long COVID. And also it's a beautiful, elegant work. And they took and examined patients after several time points after acute COVID. And you can see also that they included more than 1,000 patients. And you could see that as the patients were older, so it predicted more long COVID. And in their work, female were in the age groups of 50 to 60 and 40 to 50, females had higher risk for long COVID. If you are looking at their symptoms, it's abbreviated, but also like in our and all other works, fatigue, shortness of breath, and difficulty in returning to physical activity were the most common symptoms. And if you are looking at predictors for long COVID, then being symptomatic in the acute COVID, it was the best predictor. And actually, the number of symptoms in the acute COVID was the best predictor. So if a patient had more than 5 symptoms in the acute stage, it was the best predictors for long COVID. And this was repeated also, I remind you, in our first work, in many other works. So now maybe we can predict who will have long COVID, but we still don't know probably how to treat it. And you know, there are many centers which are doing different things. I know that some of them are giving steroids and aspirin, and others say that maybe if you give another vaccine, one of the mRNA vaccine, it will ease the symptoms. But actually, up to now, there is not even one randomized controlled clinical study to show what's really the best therapy to help those patients. And actually, what we are doing in the clinic is first to rule out other unexpected diagnoses. And we found, you know, patients with hypothyroidism, patients with heart disease, which was not connected to the COVID, patients with colonic carcinoma and anemia. So we must really rule out other diagnoses that may cause the same symptoms. Then we can try to give symptomatic relief. But what we understand is that for most of the patients, a multidisciplinary rehabilitation approach is the best thing. And this is something that we infectious disease people, we are less good in it. So actually now most of the patients are being treated in our rehabilitation center. So I really wish I would know more tomorrow. We are continuing with our studies. We are continuing to look at studies of other centers in the world. And I hope I'll have better answers in the future. You know, I remember that in the beginning of the epidemic, many patients were coming with questions. And usually I told them, I hope I will have better answers in 2 weeks. Then I understood I don't have any answer in 2 weeks. So I told them, maybe I will have some answers in 2 months. And now I don't want that I will have better answers in 2 years, but I really don't know when we'll understand deeply what's long COVID, what's the best approach to treat it, and of course, what's the best approach to treat it once people got acute COVID. But of course, if people will get vaccinated and will not have the acute COVID, then actually we are also preventing the long COVID. So one of the most important things in the prevention of long COVID is persuading the people which don't want to be vaccinated. And this is one of the things that we are doing also here in Israel, is we are telling people that they must be vaccinated, not only for the prevention of acute COVID and of infecting others, but also for preventing all those ailments of long COVID. I would like to thank you for your attention, and also for all my team, Mayan Gilboa, Oli Efros, Asaf, Taz Zilberman, Marina, and Professor Galia Rav. Thank you very much.
Well, Itzchak, Tuda Rabba for a start, for what has clearly been a very personal journey for you, and many congratulations for having seen the clinical problem and addressed it and just got on with it and started to help patients with long COVID. We have about 10 minutes to go, and there have been a lot of really, really interesting questions on the Q&A. I think maybe I'll start, and when it comes to questions that either I can't answer, then I shall hand over to my colleagues who hopefully will be able to answer them. They're not all easy. So the first one comes from Hasnain Sajjad, and I think we know the answer to that. He says, you know, how do we convince people to have a vaccine? Well, as Itzchak just said, what you need to do is to find someone with long COVID and to introduce them and say, I'm not saying the vaccine will always prevent it, because it doesn't, we know that now. But if you don't want to end up like this, just because you think it's not a serious disease because you're young and healthy, I'd have the vaccine. That's probably all I want to say on that. The next question I'm going to hand over, because I don't know the answer, and I don't think there is one, from Adrian Kiss, who says, do the monoclonal antibody therapies that we now have for acute COVID alter long COVID rates. And so I assume we're talking about Regeneron, etc. I don't know the answer to that, and I am not sure there is any well literature on that. I don't know if my colleagues might wish to comment. It looks like...
Thank you very much. I would like just to say that I'm from the Sheba Medical Center and not from Hadassah.
Oh, I'm sorry. My apologies.
That's okay. We are two very good institutions, so everything is okay. We started to give Regeneron in the last month or so because, you know, we have now a very big epidemic with the Delta type. And we will start following those patients. So actually, as I said in the talk, I hope I will have answers in the future. But meanwhile, there is not enough time since we started with Regeneron to follow up the patients. Before, we gave a very big mixtures of antibodies. Part of them were monoclonal, some were others from different companies. So it wasn't a very good methodic think that we could really do a good study. But I hope that with the Regeneron now, which is given to everybody with mild to moderate disease in the beginning, we'll be able to follow up also long COVID later.
Well, thank you very much, Itzchak, for answering that. And may I also echo Itzchak's last comments during his talk, which relates to the fact that, you know, what we really need is trials. So it's the Wild West out there. And some people may also say that even the more structured trials, some of them paid by governments, have not actually been statistically powered correctly. And we can see, for example, the remdesivir saga now, in that some people say it's fantastic and other people say it makes no difference. We still don't know the answer. Okay, Matthew Dryden has come up with a question which probably has been answered subsequent, I hope, to my colleagues' talks. He says this really looks like chronic fatigue syndrome, stroke, myalgic encephalomyelitis that was. I think, Dr. Dryden, the answer to your question is yes, of course. It has a panoply of clinical expressions that will fit with ME/CFS. Identically to ME/CSF in the early days, the doctors thought these people were depressed and needed amitriptyline. I think what COVID has done is been a disruptive innovator. And by so doing, it has made absolutely sure that just because doctors don't understand it does not mean they should say it does not exist. And I suspect, just like autoimmune disease was 40 years ago, we will start seeing branches of autoimmunity and disordered cytokine regulation, etc., playing a very, very big part in this condition of long COVID. Do my colleagues wish to add or comment or?
That was the question that we asked ourselves, you know, in the first 2 or 3 months. Is it depression? Is it some post-traumatic reaction to the epidemic? And personally, I believe many people without actually acute COVID may have suffered due to the lockdown, due to the other reasons, with concentration difficulties, etc. But if to compare it to chronic fatigue syndrome, which is really, you know, everybody is doing it because it's the most similar thing that we saw in the past, I think we'll have to do a study because really without data, I don't know how to compare them both.
Well, I agree with you. I just like to state the reason that we got the immunology study up and running in long COVID is we've been doing it in chronic fatigue syndrome. And we need some more data before we can publish that. But there are certainly some similarities there. But maybe this time next year, we should have some more answers. Kuman Kofle asks, and I hope I'm saying your name right, why is the vaccine not enough? And it appears to be a simple question. Of course, it's not. And my question to my co-presenters is, why does the vaccine not protect against long COVID anywhere near as effectively as it does against death and hospitalization? Of course, the vaccine doesn't protect against reinfection with variants either. So there are three things. There's the protection against death and serious disease. There's the protection against reinfection. And then there's a protection against long COVID. And my co-presenters might want to say something like, oh, no, they are related. But as far as I can see, the more data we have, the less the three seem to be as one, as you might imagine. We shall see. All right. Now, Bharat Patel, I think we've probably answered this question. He asked a question about what is it about long COVID that seems to do terrible things to your heart rate and give you palpitations. I think my colleague Isin has talked about that quite a lot. I'd say two things. There is clear evidence now of autoantibody involvement, as Isin showed, in autonomic dysfunction. And so it may be that those people who develop postural orthostatic tachycardia syndrome, which is what it is, simply have evanescent, they've broken tolerance to their own autonomic nervous system and their antibodies against neural end plates. That's been proven. The other thing I would say is that the one thing in our study, which was tiny, that we could not influence at all was POTS, in that every patient statistically significantly as a group had less symptoms after we'd finished, but we could do nothing. All those people with POTS continue to have that syndrome. And that may be because they have autoantibodies and antihistamines don't work against them. So I don't know about that. We were also asked a question, and this one probably is for Isin.
May I add something?
Please do, of course.
Yes. I agree that these patients might have autoantibodies against adrenergic receptors or muscarinic receptors, etc., G protein coupled autoantibodies. But they might also be suffering from small fiber neuropathy, which comes up with dysautonomia. They have autonomic symptoms. They have burning pain. So this, and also the study that I showed from Rali's Malik shows that on corneal confocal microscopy, those small fibers, the C fibers, are less in number, and they have changed their sizes, they have changed their configurations, so they are severely affected all over the body. And small fibers mediate thermosensation, they mediate pain, they mediate autonomic functions. This is another problem that these COVID-19 patients might be facing. And the other is, we know that this virus enters through the olfactory system, or it can also go through the glossopharyngeal nerve or vagal nerve, and they all converge to the brainstem. So the brainstem dysfunction is also, we can attribute this dysautonomia to the brainstem, and the hypothalamus dysfunction could be also the problem in these patients. We should be looking specifically to these areas as well. Immunological and neurological, either peripheral or central nervous system dysfunction should be addressed.
Well, thank you very much, Isin, for that. Yeah, excellent and comprehensive answer. And of course, the immunologists will see it from the T cells and the antibodies, and the neurologists will see it from the nerves. And we've got to meet in the middle. It's a bit like, you know, meeting infectious diseases in the middle between the host and the bug, but that's for another story. So we only really have about a minute left. I could ask Isin possibly to answer Dr. Kiprotich's question offline relating to flunarizine, which is not available in the UK. It's a calcium channel blocker, and it's apparently really good for headaches, but that doctor wanted to know about that. I think with 30 seconds left, probably, though, I should first of all thank my colleagues for some really, really excellent talks. I'd like to personally thank Matt Dryden and ISAC for organizing something that has taught me an enormous amount today. And I'd also like to thank all the organizers and also all of you who've been running this Zoom meeting so well. And on that note, I shall say thank you very much for attending. It's been great. And I look forward to being on the receiving end next time for the next ISAC Zoom meeting. So thank you very much, everybody, and have a great day.
Thank you so much.
Bye-bye.
Bye.